Hi, good afternoon, everyone. Hope you've had a productive Monday. Thanks for joining this update webinar on community mental health transformation. We had one last year. Amanda kindly explained the framework. And then we also had a bit of a polling during our faculty annual conference where there was still some kind of a lack of understanding and also local engagement. So we thought we will do an update on the nuts and bolts of community mental health transformation as an old age psychiatry faculty, how we can share that information for practicing clinicians, that you are able to go back to your local services, local ICS, to make sure that our old age psychiatry is well represented. We have got none other than Dr. Amanda Thompsell, who is the National Specialist Advisor for Older People Mental Health with NHS England, and the community mental health transformation specifically for older adults is a passion for Amanda. She has worked long and hard, shaping this, and also have got lots and lots of various tips on how we engage with the transformation agenda. So without further ado, I would like to bring Amanda. I just want to get some housekeeping. This we aimed for about 3/4 of an hour, and there are some questions that already people have raised, and please use the question and answer function for you to put your questions. We've got our Vice Chair Josie Jenkinson, who is in the background moderating the questions, and then towards the end we will try to answer some of the questions. If we are not able to answer all of them, we'll try to put some of the comments back and try to summarize them. And Hope you will benefit from it. My plea is identify who is your local ICS lead, see whether there is an old age psychiatry representation, and make sure that your services are well represented. Without further ado, I'm going to bring Amanda Thompsell into the webinar. Welcome, Amanda. Thank you for your help.
Oh, well, thank you, Krish, and the faculty executive for allowing me to come and talk at this webinar. And also thank you for Kitty and her team who are in the background making this all work. So can I have the next slide, please? So what I want to do is just say that I'm going to go through the background, trying to explain how we got to where we are, and then talk about what the community mental health transformation is about. I'm not going to spend too long on that because I know you've heard me talk about that quite a lot, but what's been in some of the plans, and then the practicalities about how do you go about implementing these plans for older adults. Then we'll move on to co-production, and Krish is going to help out here because he's going to share his example of co-production within his services. And then I'm going to end with my contact details. And I really do want to know what is working and what's not working, so I can then pass that on to NHSE I about getting a true picture of what it's like on the ground. So next slide, please. Krish has already mentioned this faculty conference questions, and as you could see, only 15% knew what their plans were, and they didn't know who to contact. So this is not a very good place to be in, especially when you're the people who will be actively engaged in this transformation. However, the good news is that at the moment, it's just skeleton plans that have been agreed, and it's all about the implementation. So it's not too late, and you can really make a huge difference. So next slide. I just want to go back to 2016, and I know it's a long time ago, but you may recall the 5-year forward view for mental health made little mention of the specific needs of older people, and we were all rather upset about that. And then we produced the Suffering in Silence report, and I put in red what we asked for. So a clear vision for older people's mental health service is to be included, and it's to rebalance the resources towards older people's mental health, rebuild, have equitable and effective access, and strengthen the workforce. So it's to specifically avoid older people being ignored that the Community Mental Health Transformation Plan says working age and older adults. And the fact they had to put in a separate proposal for older adults was really building on this. Next slide, please. So I've had some questions from people, so that's helped me to formulate what I put on these slides. So it's not about the Department of Health and Social Care White's paper. And the fundamental thing, it's funding for older people with functional mental health problems. Now, we know that older people don't divide into pure functional, pure dementia, and they often a crossover. So they may have coexisting cognitive issues or dementia, as well as frailty and substance abuse. And I think that it's really important. The questions I often get asked are about dementia services, about dementia training. This is about functional mental health problems. Okay, so just bear that in mind. So next slide, please. I just want to say that there is, however, 17 million as part of COVID recovery, which is specifically for dementia. So that's COVID recovery, and it's for helping people who are waiting for an assessment. How you actually use that locally hasn't been prescribed. So this is 17 million across the country that relates to dementia, but that's not what we're talking about here. So what we're talking about is the community mental health transformation. So somebody asked me if they could actually put in their plans. Well, the plans have all been put in and they've been agreed. And so funding is starting in June. So 121 million to start with, increasing to 295 million in 22-23 to 366 million in 23-24. So in all, 782 million from the transformation money, plus there's the CCG baseline money as well. So and there's also some COVID recovery money, but I'm not sure what we're going to get with that. So the other thing to really bear in mind, that each ICS, as part of their community mental health transformation for adults and older adults and working age adults, also has to deliver on 3 pathways, which are focusing on eating disorders, personality disorders, and rehabilitation. Now, to start with, they don't have to do all 3 pathways. They can choose the first 2 and then work on them. But again, NHS England made it clear that these pathways had to be accessible by older adults. So none of that separation, oh, that you can't get this service. Okay, next slide, please. I put this in here because this is how NHS England are assessed and then what they're aiming to deliver. And as you can see, I particularly put in red, they are going to be delivering on the approved transformation proposals, and they're going to check that the money does come through. We need to make sure that we're getting the fair money for your local services in relation to older adults. You can also see this spending review requirement, particularly focusing on the mental health practitioner role, the peer support, and the voluntary sector. Now, all of those could potentially be of benefit to us if the people actually know something about older adults' mental health. So I think that's something that we've really got to make sure that at a local level that you're talking to the PCNs about this. Okay, so the next slide, please. So I just wanted to remind people what issues the community transformation is specifically intending to address. So I don't think any of us would actually disagree with this. We don't want repeat assessments. We don't want them to be excluded. And I know I've already had a question from Tony Rowell about substance misuse. And it's about people being able to access services. But obviously, this has all got to be part of your local plan. This is not from above saying you've got to have this that service, you've got to work out what it is that you've got, and that's what resources you've already got there and what you need to have to make sure that you're providing a good service for older people and you can meet their needs. It's to stop silo working and for people to be just discharged to no support. And we've already mentioned the access to specialist services. Next slide, please. I'm actually going to, I'm going to read this while you, I'm apologising for actually reading, but I think it's important that you hear what the mental health implementation plan said. Older people's access to mental health support will be based on needs. Well, we'd already done that with James Warner's work and not age. Services will deliver this through an integrated approach focused on the person's identified care and support needs across mental and physical health, social care and voluntary sector boundaries. In practice, this will mean older people's mental health services will work more closely with physical health services such as the Ageing Well, and you can see that kind of blue section, Ageing Well, services through a shared care approach and joint management to provide a joined up care around the individual. So that is the vision. I mean, we've always worked together with other community services, but we will have to make some adaptations to this integrated way of working. And in particular, there'll be a need to upskill our colleagues because we can't be everywhere doing everything. So it'll be making sure that they have some knowledge about mental health needs in older adults. Okay, next slide, please. Now, this is looking at the plans that were submitted. This is about thinking radically differently to the way that we've delivered services before. So not every single one of these things was in every single plan, but the key ones that were there, most of them talked about co-production, I mean, because that is key, and integrated MDT working, and the need to train up colleagues. In particular, this is to do with functional mental health, not dementia specifically. So they've also, some of them have been really good plans, looking at what were the actual services they had now, and looking at the local demographic profiles to assess what the demand and the capacity were going to be for older adult services. A lot of them talked about contracting with the voluntary sector, making sure that older people weren't digitally excluded. Now, they were asked to find a named SDP, will now be ICS-wide lead for older people's mental health care. I'll come on to that in a minute. So while not all of them had all of this, these are the kind of elements that were in those plans. And I think that what it is now, we're going to take these plans and actually make them into a vision that works for your local community. So it's about one system, ease of access and entry, joining up a personalised care where everybody is working together. I hope that explains it, but if you've got any questions, then come back to me. But I think that I need to just clarify a couple of other points. Next slide, please. The main criticism here is that it's all going to be ageless. So this is a quote from NHS. Any move towards ageless services should not constitute a move towards services that lack older people's mental health skills and expertise. So it might well be that you have a service that is for everyone, but it has older people's mental health skills and expertise as a recognised component to it. So that might be a way forward, but it's not saying then that we want to all go to ageless and that older people don't need specialist services and expertise. So I think that is helpful. And then another thing that I think is really important when you're thinking about engaging is this NHS mental health implementation plan. I put in bold, says that all systems will be required to work with local clinical experts. I mean, clearly it's users, families, but from the point of view of this presentation, they are meant to be working with yourselves. So if you haven't been involved, it is in the implementation plan. And then the last one is from the early implementer sites, finding that because they were across so many different areas, that they provide a much more consultation, advice, support and supervision role, rather than having a small caseload of people that they looked after. It's a kind of slightly different way of modelling. So the next slide, and probably the most important slide, is to write down this lovely lady's email address. So she's a wonderful colleague who's agreed for you to email her. And what she will do is, if you give your region and your ICS, she will then send you the email of the people to contact for you to for you to email them and saying, can you show me our local plan for older people's mental health, and can you tell me who the older person's mental health lead is and who is going to be the clinical contact with them, who's going to make sure that the solutions that are being developed really have that input from the clinical services. So if we go on to the next slide, you'll see a list of the regions and the ICSs. So it's a bit kind of, I'm hoping you can read it. I know it's a bit small, but try and get it all on one slide. So I've realised that there are some people whose mental health trusts go across but 2 ICSs, and I think it's really worth you asking for both, or maybe you even go across 3. The reason is because there's quite a lot of variation between the ICS plans, and it's really worth you seeing them, because you might well be able to help bring good bits from one to the other and vice versa, and share learning. So next slide, please. I hope you've got that. So this is moving on to the practicalities. So I really do want to hear from yourselves what's working, because some of you are further on than others. But it's also about where the barriers are. And again, I can try and see, I might not have all the solutions, but at least I can ask the right questions if I know what the problems are. So next slide, please. There are some fundamental steps that have to be in place. So one of the ones is about leadership. You must make sure that you have senior people with the ability to get the buy-in and sign off. I mean, there's no point in being there if you can't actually make decisions. And it's about having those people with a knowledge of mental illness and have a clear purpose for these meetings, so that you can then build on these alliances and plan your way forward. But these alliances are ones that we already have. You know your PCNs, you know your voluntary sector. It's building on those, particularly having a shared vision and being honest about those relationships. To get the most from the transformation, it's really helpful if you know your local demographic information, particularly that you can know the numbers where you've got maybe particular ethnic groups which you are perhaps not able to reach, and then you could really then target your services to be able to do the whole population that you're covering. I think that the other thing that is really important is to scope what your assets are. For example, not only health, mental and physical, what about social, where's the housing, what about the finances, what voluntary sectors are available for older people. And then when you've got that, you can then, with older people and the voluntary sector and the GPs and the physical health geriatricians, and local authorities all come together to develop a model that actually takes into account everybody's insights, but also helps you to give a focus to a model that will actually work. Because there's so many bits of information that it's difficult to hold, and everybody comes from a slightly different perspective. But it's really important when you're thinking about whatever model that you're also thinking about workforce, because there will be some need to be some recruitment, but it's also about where these new workforces are coming in. Maybe there might be allied health professionals, maybe they might be prescribers. Where do all they fit, and what are their skill sets around older adults' mental health? Next slide, please. So I wanted to put down some of the enablers. I think the fact that I've heard, oh, well, it's all the money is going to go to adults, nothing's going to come to older adults. I think it's really important that you actually keep in mind that the framework specifically says older adults. So any of this excuse about, oh, well, we'll do it next year, that's not what it's about. It's about doing it now. It's about also finding allies. And as I said, I think we're uniquely placed. We know our local community really well. And I think that if you can talk to them and let them kind of see your point of view and you see theirs, then you can put together a joint vision, which will be very powerful, particularly involving experts by experience. People listen to these experts far more than they listen to clinicians, I find, and they involve primary care from the start. One of the questions that I find particularly useful is how will this change improve the care for older people with mental health needs? And that's when having some case studies can be really helpful, because if everybody's going to be in exactly the same situation, then that's not what it's about. It's to actually improve the care that we can deliver to older people. The other thing that really is needed is to make sure that everybody in the room understands the difference between types of support and presentation that older adults have as opposed to those of working age, because I put unknown unknowns because it's kind of, we know it, but sometimes we forget that perhaps other people who are there don't know it. And I think it's really making sure that they do understand that fact. It's really, as you know, that COVID has affected some groups of individuals more than others, and particularly older people, but also in different ethnicities. So anything that you are doing that can address these inequalities will be really useful and worth pointing out. And then having an older adult champion at all levels of the transformation in the local authority and the social care in the PCNs. If you have those, you're much more likely to have those local organisations thinking about it. Okay, next slide, please. I'm coming to the end, you'll be pleased to hear. So how will you these are other points to consider. When we talk about training up colleagues across all the sectors, so local authority, voluntary sector, peer support, mental health practitioners, what resources are needed for this? I know that the faculty has produced some PowerPoints to help, but that will need time and that needs to be factored into your conversations. I've already talked about these new roles in the PCNs, which are coming now, but there are also other work streams such as crisis care, urgent community response, enhanced care in care homes. And are you aligned to that? I think that's really important, because something like the enhanced care in care homes, one of the 4 priorities, other than falls and pressure sores, is actually older people's mental health and dementia. So again, could you collaborate with other services, maybe the dementia services, to help improve, or rather increase, the community workforce? I can't consider enablers without also mentioning potential obstacles. So next slide, please. I think COVID obviously has had a huge impact on everybody's workload. So, you know, it is difficult to find time, and there's all these changing environments where ICSs, PCNs, all of the changes in the voluntary sector as well, makes it a challenging time. But it is a unique opportunity for us to make a difference to older people. I think that sometimes that people say, well, what's the evidence base? Why are you doing that? And I think that generally there is a relatively poor evidence base compared to, say, some of the other things, maybe, say, in eating disorders and things. So we just have to accept that. But I think that shouldn't stop us striving to make sure that older people get the best care possible. I've talked about the lack of knowledge, and I've also talked about how often our older adults are not, our patients are not necessarily as vocal. And I suppose I've said we're not being bold enough. I think that's because we're so used to not getting anything and being the Cinderella service that we feel that, well, it's not going to change. And I think that this is our time to be able to make a difference. And I think that what's happened is that NHSE and I have tried their best to put together structures to make sure that we do get heard, and it's now in the actual implementation that we need to ensure that we seize this opportunity. So next slide. This is about co-production, and I have heard of people say, yes, I've come up with a wonderful solution and I'm going to show the experts by experience, or I'm going to show my local authority colleagues. That's not what co-production is. So I'm going to hand over. Krish, could you, disembodied voice, tell me about your co-production, please?
Yeah, thanks, Amanda. I think what I just want to quickly describe is, again, co-production would need to be in the real term of co-production. I think our colleagues, our patient representatives and patient leaders will agree that it shouldn't be a tokenistic way of having a co-production. I got told off once when we tried to send a delirium guidelines for their opinion. They told me, you didn't include us into setting up and actually writing the guidelines. You're just asking for our opinion, and that's a clear message that if co-production should be in real sense whatever we set out to do. And in our trust, the details will be in the future platform, where we've got like how we have our clinical governance groups from professionals. We used to have like a shadow of them running every week, where we've got patient and carer representative forming a group and running a weekly meeting on how our services are run and governed. And that has made a significant impact on getting their voices heard and getting our voices heard. And just to give like a couple of quotes from them, they felt that they were able to be involved in interviews, running consultant interviews, reviewing, developing leaflets, and the key things they said was it was groundbreaking. They felt that they were able to react, respond, and reform. They felt as an observer and an outside observer, and they felt united, and they also felt that their potentials were used and it was priceless, and it gave them a bit of a peer support, and they created their own mnemonic as a group: groundbreaking, resilient, open, understanding, and participate. The information will be available, clearly indicating a power of our patient leaders. Thank you, Amanda.
Yeah. Next slide, please. So the last, this is a slide of resources. It will be on the, I'll try and get them down. The slides will be on the faculty webpage, but it's just to give you some of the links to the transformation, the implementation plan, about equalities, and particularly the focus on COVID in tackling health inequalities, where older people have been particularly impacted. Then I've given you the fingertips, which gives you some demographic details you can break down by the CCGs and your local areas. The futures page is where you can share, there are some shared resources. The training material is for any training that you want to do around older people's mental health. It's not totally comprehensive, but it gives you a good start, and it's based loosely on the HE core competencies. Really worth looking at that if you haven't heard about the HE core competencies. Benchmarking data, I've gone on and on about this. You're probably fed up with that. And I've had a meeting earlier on today, and looking about a couple of months, but it is coming out. So it's not got pushed away. It's going to come out, and it's going to kind of hopefully give us messages about where our services are not actually there, maybe in crisis. Not everybody has access to a crisis service. So next slide, please. So I put my email address. If you want to share good practice, fantastic. I want to know, because then we can actually put that on the futures page, and then we can get people to be able to know where to go for advice. If there are any barriers, so we've heard of barriers that I don't know who to contact, I wasn't involved in the plans, or that you might have other barriers that come up as you're trying to implement this. Oh, if you have any queries, I may not know the answer, but I will try and find it out for you. And it's by sharing these practices and obstacles that we can then try and learn from them and make it better for everybody. And that's it. I can shut up now. Thank you very much.
Hi everybody, thank you so much, Amanda. That's wonderful. You spent so much time over the last few months trying to spread the message about community mental health transformation. We're so grateful. I've seen a few messages come up on Q&A, and hopefully some more will come up as we start talking again. I think we should probably start with, we've spoken about this a lot before, but this question that keeps coming up about can you explain why there would be a separation of functional from organic services for older people? That's from Sean Lennon. Oh, you're on mute, Amanda.
It's not meant to be a separation. What it was that, as you know, there was a big focus about dementia, and there was no focus on older people's mental health. Now, when you put together the community mental health transformation, that was for adults. Now, adults don't particularly have dementia, so to make it a separate one, to make it for older adults, they were covering the same conditions, which were functional mental illness, and that's why dementia wasn't included. It came with the whole of community mental health services. I accept that we often have both, but this money is for functional mental illness.
And I guess for me, the question is about the money is coming from different pots, but that doesn't, how does that look in practice? So obviously we know there are going to be people that will have more than one diagnosis, will have dementia and SMI, and the money to fund care for these people may come from different pots. The question for me has always been how to bring those two things together. I don't know if you have any thoughts on that.
It's difficult because it's coming partly from the money from the CCGs and for the transformation money. There are other pots of money, which makes it even more confusing for crisis. There's other pots of money for liaison. There's other pots of money for suicide. There's other pots. So there's lots of different pots of money, but they are having to put in the financial plans. And I was, and just earlier today, I was saying that it's really important that when they look at the money, that there is a level for older people's mental health, and then the dementia will fit across with aging well as well. And then aging well has the care homes in it. And yet, of course, there's mental health and there's dementia in that. But it's going to be difficult to tease it out. But I think that it's the baseline is, have they put money for the community mental health transformation into older adults? I don't want to see a lovely thing for at working age and nothing for older adults. But I think we need to keep asking.
Absolutely, and I guess that's why it's so important that people who are leading these plans have a good understanding of the wider landscape in terms of older people's mental health needs and what else is happening in these other areas of older people's mental health services.
I think that's really important. What I'm struck with that Vicky was very kindly, she's done a lot of work in trying to get some contact details for you for each ICS. But I didn't see a lot of clinicians. I'm sure the clinicians are busy doing their clinical work, and there's a lot of scoping and being in meetings about finances that we probably don't need to be in. But there does need to be a link between a clinician, and I would say if we're talking about community mental health transformation, it's going to be a jobbing clinician who knows something about the community. I mean, I remember, being inpatient, that I'm just not quite as up to date with what's in the community. So it's somebody with experience. It doesn't have to be a psychiatrist. Obviously, as a psychiatrist, I'm pro that, but it could be a psychologist, or it could be an occupational therapist who really knows what it's like to look after people with older people with mental health needs, and that they are feeding in. And if they're not, I think we should challenge that. And if they're not going to listen, then let me know, and then I will feed that back.
Thank you, Amanda. Let's move on to a different question. It's an anonymous question. Anonymous says, I've struggled in the past to offer a consultation model of care to a frailty service, as it can be hard to measure the activity. And I was asked to open referral, do a risk assessment, cluster, etc., etc., etc. I could spend a long time with one patient, but really struggle to offer advice to a frailty MDT because of how mental health trusts measure activity and the requirements in terms of data. I wonder if you've got any thoughts about that. I totally get where this person is coming from.
No, I totally get that. And that I think that's really interesting. And in fact, Josie has got a data conference coming up and later in March, in May.
Amanda, I'll put the link in the Q&A.
But I mean, what we're saying, and I think if you look at the rethink guidance around ICSs, that if we're going to be working as an integrated system with voluntary care sector and with local authority, they are not going to fill in all of that. We've got to find data. This is about our data being driven by the service development. It's not going to be the same sort of way. It's not us having to do that in the same way. It's not going to be realistic if you're going to be doing all of that. So I think we're going to have to come up, and as it sounds as though you know very well what data would be useful and what data other people could help fill in as well, so that you could have the right data done once, not constantly repeated.
It just sounds like if trusts are going to provide much more of this kind of consultation model, which I see very much as like community liaison, actually, it's just providing interface with all these different community teams, then the requirements in terms of the amount of admin that you have to do your end need to be trimmed down. Otherwise, that sort of model doesn't work at all. You have to just be able to give quite a succinct, rapid input and not have to spend ages inputting the data.
Yeah, I mean, there'll be still clearly some people will be very complex and they'll need a much more intensive. But one would hope that what you're doing be upskilling some of your colleagues in the Aging Well Frailty Clinic to be able to manage things in a way, and that you'll have maybe a peer support worker who will provide some support where previously perhaps you would have kept them on the books because there was going to be nothing else for them in the local community. So there might be all of that. But I think this is absolutely where the leadership, the clinical leadership, is going to be needed in designing this type of data. And I think they're particularly in Somerset, they're really looking at the data. So it's worth looking at their system, because they're having to revamp all their data, because otherwise it's not going to work.
Lovely, thank you. Okay, so in the interest of time, then we'll move on to another question from Andy Galagli. I hope I've said that right. So some years ago, we started handing lithium monitoring to GPs. Would returning this in-house be a possible development, as they haven't always done it too well with nephrology support?
Interesting. And it's all going to be what your local area, what's your need, how many people you are. Does it have to be us? Could it be a pharmacist? One of these, because again, talking about the allied health professional roles, could they manage it? Does it, you know, could we think about a different way of I mean, there are some GPs who run clinics. We're talking about outreach ECG clinics, maybe outreach lithium clinics, or general health clinics that covering all SMI, but particularly could do lithium. I don't know. It's really going to be, what is your local situation, what's your local numbers, and what's your local wish for with your older people with bipolar disorder or resistant depression. What do they want? What would work?
Thank you. So as before, it really boils down to what would work for your local population and really thinking about it. Really good question from Rashi Negi. Hello, Rashi. Thank you so much, Amanda, for such a clear presentation. Just wondered if you have any opinion on the background of this transformation as to why these 3 subspecialty areas were chosen, even though demographically older people's needs and frailty should have been the main focus.
I don't know. I have no idea it was you know, I didn't even know it was there till it was there. So I really don't know. I mean, obviously, with COVID, eating disorders is very much in the agenda, up the agenda. So I presume that might be rehab, probably because of the out of area placements and a real push for that, because there's not enough rehab, and then possibly the personality is because there was always concern that they weren't getting enough services. So, but yeah, we could go on to Tony's alcohol, or we could go on to the frailty. There are so many different areas. I don't know why.
Thank you. It's a really good question, isn't it? Okay.
That very good article by Prof. Howard in Advances about personality disorders and just how potentially underdiagnosed there are, and those could be a lot more, and we haven't really had very much to offer them. We've seen people with personality disorders, we haven't really had the services to offer them. So I think that when one's talking about the pathways, that they need to make sure that those services will be accessible to older people. And I think, again, that's something about looking at your books and seeing roughly what type of, how many do you think you might have? Because when you really think about it, I think it's probably a bit more than we've, you know, thought about as a diagnosis.
Thank you. If you have the link to that paper, it'd be great if you could send it.
Yeah, I definitely can. I'm not sure I can find it at this second, but yes, I will definitely send it. No, I'll send that.
I'm just wondering out loud if it might have been related to NICE guidance at all with those specific issues. Do you know?
I don't know. Obviously, we've had, you know, a lot of tragedies of people with eating disorders and personality disorders, and people being out of area. So I think all of those, I mean, they're all valid things to really try and get right for people who have their conditions.
Thank you. Okay, we'll move on to another question now. Okay. I'm not sure who this is from because the question is the person's name in Q&A, but anyway. Can this money be used for more staff in older people's CMHTs, including medical staff? I'm guessing the answer is yes, it depends what you decide locally.
Yes, absolutely. But bear in mind that when I was thinking about that, is it going to be just one, you know, that how much you can spread out that staff? So if we choose a nice expensive doctor, then could you have had, I don't know, 4 allied health professionals or something? I don't know. Do you know what I mean? You'll have to think about how that member of staff is going to make a difference. But you might well have to employ staff, because if you're training up staff, you're going to be taken away from the clinical work. You can't be training and doing your clinical work and helping with their vision. There's got to be some give to this system, and so you're going to have to think about who's the best person to provide that type of support. So yeah, anything's up for grabs, but you do need to think why you're doing it and what would be the long term. So this isn't just kind of prop up, this is to really redevelop the whole way we deliver services for older people for the future. So it's not a kind of quick fix and then, oh well, when they've gone it's all finished. That's what it's about. It's to try and permanently rechange things so that it's going to be a sustainable solution.
Thank you. Okay, aware we're coming up to 4:45. Are you okay to carry on answering a few questions?
Yeah.
Thank you. Okay, so next anonymous question. Is this about separating CMHT into functional and organic teams? It sounds much more fragmented to me.
Oh, I definitely don't think so. I think that we've got so much to do that I think that it's actually upskilling maybe the CMHTs to do. I mean, I think they already do look after people with dementia anyway, but maybe not having such a hard barrier. Maybe the people who are so skilled in specifically looking after people with dementia, they're used to dealing with people with psychotic symptoms, they're used to dealing with anxiety and distressed carers, depressed carers. So they're really doing a lot of CMHT work. So maybe it's actually using all of our resources in a slightly different way. Throw that out at you.
Thank you. Okay, another question from Karen Franks. In the northeastern Cumbria, we're the biggest ICS in the country by population. As I have a clinical network role, I've had some involvement and my name may come up as a contact. We have over 30 PCNs and 4 ICPs, at which level frailty ageing well work is developing. We are told, and I agree, this work needs to be driven at a local level, but with little agreement at what level this is. As such, as having a little involvement at ICS level, I have little influence or power with regards to specific plans, other than constantly waving the flag for older people's mental health. I guess it's more of a reflection of what things are happening. How things are.
Well, you should be having more power up to up to now it's been developing these plans, which, as I said, are very skeletal, and it's really that development locally. So hopefully there are some leads in your different ICSs, the 4. Not helpful that it's we go across so many, but hopefully then you would be able to input into that and then be part of that stakeholder group when they're getting the local authority, the PCN, the experts by experience, the voluntary sector, the housing, finance, all together, social services all together. And then you would be able to have some input into that so that then they develop services that are actually useful for you. But it's going to need, I would suggest that the older person's mental health lead will have to know the demographics of their particular ICS, the need, and also what the capacity is of mental health services to deliver. And this, I mean, even on the community mental health transformation, it mentioned there has been underinvestment. There needs to be some investment into this. So it's going to be hard because she's got so many different ICSs, but I would suggest it will also need some of her colleagues to step up and support her.
Brilliant. Thank you. Okay. Kapila's made a good point just in the Q&A that the reason that these 3 main issues were taken was related to complexity and the problems that GPs faced in managing these patients. Also that frailty was considered as part of dementia service provision. Balaju Wuntakal has asked if it's possible to share the document on ageing well where dementia services are mentioned.
Where dementia services are mentioned, they're more mentioned about in the community mental health transformation, where it specifically says you have to link with ageing well. So it is in that community mental health transformation document, and in the NHSE I, but I will get that link for you.
Thanks. I think it is useful, particularly if it's not actually in ageing well, if it is in the community.
Well, in ageing well, they talk about it, but they're not going to talk about community mental health services. They're going to talk about seeing seeing people with dementia and saying that we have to link in with them. But we specifically got in the implementation plan, and which I've given a link to, and also in the NHSE for the plans for the community mental health transformation, they specifically said you need to link in. So that actual quote that I read out came from the implementation plan.
Lovely. Okay, thanks for clarifying that. I think that's the end of the questions. I would just like to add one of my own, if that's all right, Amanda.
Yeah.
Cheeky. Have you come across examples where really good plans have been drawn up that you're very impressed by, and what do they look like?
Oh, well, yeah, I have. I did see them all, well, other than one, because there was potential conflict of interest on the one. One had virtually every single thing on that plan, those key elements, had virtually every single one. And I was just thinking, I want to move there. It was lovely. Now, how they're going to deliver it is a different thing, but they talked about, first of all, they talked about the demographics. So that bit that we all know that we've got, isn't it, 18% of the population in 2018, and then going up to 24% of older population in 2038. But in particular, they had it done for their local area, and they could see it had gone up. And then they had looked at what resources they had, and they realised that they were under-resourced for that. So they were then talking about employing more staff. It didn't actually say medical staff, but they were going to look at the recruitment. They were going to have a look at the training needs. They were going to link with the voluntary sector to get peer support workers and voluntary sector to actually meet the needs of older people. They were aware of the digital exclusion within their local area. They'd planned to work with the GPs in an integrated ways with the PCNs, and they were already linked with frailty and with the care homes. And obviously all the plans were going to be co-produced going forward. So you looked at that and you thought, wow, I want to go there. So yes, I mean, the visions, some of them were absolutely amazing. Others were not so good, but they were amended. So they've all got something, all got key elements, which are the co-production and the MDT integrated working. So they all, in the end, because I only saw the initial stages, they all then got feedback and then amended them. So they've all got some key elements. There's none of you will have an ICS that won't have a vision. And so none of you have an ICS which doesn't want to improve things for older people. They just don't necessarily know how to do it. And that's where with the clinical input is so necessary.
And have you come across any implementation plans yet, Amanda? Any particularly good ones?
Well, it's only just really starting now, because the money's only just coming through, and they're having to. And the thing is that I know that Farouk was saying that they have many stakeholder meetings, and they've already got that up. I think some places have really got that stakeholder working. Somerset particularly got some. Lambeth has got an alliance. Not necessarily for older people, but there are, those that integrated working. Then we've got people doing joint induction, joint training, so that everybody comes together. When you join the organisation, then you all got a basics of the same way going forward. So there are lots of different bits of good practice going on, and some of the obviously the early implementer sites are even further forward with the integration between health and mental health services. Particularly Cambridge does quite a lot.
Brilliant. Would there be a way for people to share their implementation plans?
Absolutely. The Futures platform is really worth going on. We do, we have a separate section, and I didn't want to go through all that again, but it was an older people's mental health, and people can ask questions, and they say, has anybody, like with the lithium, we could say, how's that working in your local area? Have you got any innovative ways for that to work. So, you know, there are different ways that we could share things and also ask each other what we've got, because it's wider than just health. It's social care, ambulance service, everything coming in.
Brilliant. And the link to the Futures platform is on your last slide, isn't it? And the slides will be on our faculty.
And if you have any difficulty getting onto it, then just let me know. Once you've got on, you can then see Aging Well if you're really interested in that, or care homes, whatever you're interested in. But in older people's mental health, we have got papers and things relating to personalities or disorder or eating disorder or community mental health transformation.
Brilliant. Thank you so much, Amanda. So I think we'll wrap up there if that's okay with you. But can I ask you, if you have one take-home message for the audience today, what would it be?
Email Vicky straight after this and find out who the person is that claims to know how to get the long-term plan and possibly claims to be older people's mental health lead. If they don't say they're the older people's mental health lead, then say, well, who on earth then is it? And if they don't have it, then well, who's going to be it? Do you want to be it? But it might be that it's too kind of managerial and will take you away clinically. But I do think you have to say, whoever it is, I need to be the clinical lead and kind of moving this forward to tell you what you don't know really, and to help you to come up with a solution that would actually work from a clinical point of view, as well as making sure we've heard all the other points of view. But as I've said to you before, and I know I've got to quickly wrap up, they have said it needs to involve older people's mental health clinical experts. It's specifically written there. So there's no excuse, and I will bang the drum for hearing from us.
Brilliant, thank you. So yeah, get involved, and it's vicky.cartwright2, isn't it? vicky.cartwright2@nhs.net, and the email address is in your slides, which will be on the faculty web pages. And you just need to know which ICS you're in.
Region and ICS. And if it's more, or Karen's got 4 of them, but you know, then just put them all in, because you'll see that there is quite a lot of variation.
Lovely. Okay, well, thank you so much, Amanda, and thank you also, obviously, to all the team at the college for helping us make this webinar happen. I don't know if Krish wanted to say anything. I know he's a super busy man.
Yeah, I'm here, I'm listening. So I think, again, thank you, Josie, for, handling all the questions, and Amanda, as always, wealth of information. Just to add extra point, the Futures website, you do need to have a sign in, but once you have signed in, you can have all the information, and the slides and recording will be available in our faculty resource page. I've also managed to get 2 of our executive committee members who had some positive engagement examples, Kapila Sachdeva and Farooq Khan. So I've put like a little paragraph of what they have done. We'll add that information as well. I think Karen Franks' reflection is right. Sometimes they do have it as a tokenistic way, but as a clinician, as a clinical leader, as Amanda rightly pointed out, we need to make waves, apart from flagging. We just need to say, how can I get involved? And it's not somebody's business, it's our business. And if you do have specific engagement issues, please flag it up with me and Amanda, because we need to be representing our faculty, and we should be explaining that if X place is not having that clinical leadership, we should know, and then we can. I think Dr. Alistair Burns will, Professor Burns will be also quite keen to know where are the blocks. So thank you everyone, and hope you all are staying safe and have you had your vaccination, and be safe, and wherever you are driving to or walking to from your working from home, have a safe journey.
Thank you. Bye, everybody.
Bye. Thank you.